All right, welcome everyone, and thank you so much for joining us today for our final session of the Maryland Reproductive Health Roundtable Virtual Learning Series for summer 2022. Across Maryland, in our work within or connected to healthcare, we strive to support folks to live a safe and healthy life and be free to define their own path. When people can make decisions that are best for their lives, families thrive, and we build communities where each of us can participate with dignity and equality. So this really plays into today's discussion. The decision about whether, when, and how to become a parent is one of the most important life decisions a person can make. People should have access to the full spectrum of health care, which does include birth control, abortion, prenatal care, and parenting support, so they can make the decision that is best for themselves and their families. Abortion and birth control are both essential parts of healthcare and do different things. Both birth control prevents pregnancy, while abortion ends a pregnancy. Both should be readily available, affordable, and always accessible so people can make the decision that are best for themselves. Abortion care is a necessary and integral part of the full spectrum of healthcare. Abortion is healthcare. In today's session, our closing session for the 2022 Reproductive Health Roundtable Virtual Learning Series, we are going to have Dr. Kyle Bukowski, the Chief Medical Officer of Planned Parenthood of Maryland, talk about what we anticipate the future of abortion care to look like here in Maryland and beyond in this post-Roe US. Dr. Kyle Bukowski, his, is a board-certified obstetrician gynecologist. Dr. Bukowski's clinical experience includes complex family planning, including first and second trimester abortion, colposcopy, gender-affirming care, and complex gynecologic care. Providing comprehensive, evidence-based, high-quality sexual and reproductive health care is his passion and drives his interests in advocacy, LGBTQI health, medical education, and improving access for our most vulnerable communities. In his free time, Kyle and his husband, John, enjoy hiking with their dogs and finding the tastiest food in any city they are exploring, which is a wonderful kickoff as we imagine this next upcoming long weekend. So for today's session, I wish us all to give a warm welcome to today's speaker, Dr. Kyle Bukowski.
Thank you, Charlotte. Good afternoon, everybody. Really happy to be back. As a gynecologist, I feel like I'm in a much more appropriate space for me, not talking about men's health this time, but talking about reproductive health care, is particularly related to pregnancy care, since that definitely is, my passion and where I spend a lot of my professional time. I really appreciate the intro. I think in a healthcare space, talking about abortion, we have to be really thoughtful and intentional about recognizing when we're talking about abortion from a public health and health framework versus when we're talking about abortion maybe from a political or moral sort of conversation. And I just want to wholly recognize that everybody comes to this conversation with very different perspectives and places. I was raised in a really anti-choice home in a very conservative part of the South. And so I recognize that people come to this conversation with a lot of different perspectives and views. And I really just want to ground us and say that we're having a conversation about healthcare, and particularly about the health of vast communities, entire regions of the country that are going to have different healthcare outcomes because of decisions around the regulation of abortion. So our objective today, I think any conversation about abortion always needs to start with some basic understanding of incidence and demographics of abortion care in the United States. Want to recognize that probably the vast majority of you are not abortion providers. And so I thought it would be a good time to just, kind of get up to date with what are the current methods of induced abortion that are available to patients. What does that look like on the ground when you're referring a patient for an abortion or patients asking you questions? And then I don't think any conversation would be complete at this point without talking about kind of the state of play with relation to abortion restrictions across the country following the Jackson Women's Health decision on June 24th. So My previous boss was a former Navy doctor, and she always started with her bottom line up front. So kind of up front, abortion is common, extremely safe. Methods of induced abortion include medication abortion, uterine aspiration, and D&E. And without a federal protection, there is now a patchwork of banned and preserved abortion access that now exists in the United States, with the most vulnerable populations bearing the most harm by these bans. So let's talk about first abortions in the US. So this is data by pregnancy intention status. And so it's a little dated, right? 2011 was 12 years ago or 11 years ago. Kind of horrifying to think about. But these numbers have not changed significantly. There has been a slight decrease in the unintended pregnancy rate, which is awesome. It means we're doing a good job as family planning providers. But just as a review, in 2011, 6 million pregnancies, and a little over half were intended, meaning that they were planned and actively trying to get pregnant, and 45%. And we recognize that unintended is lacking in some granular detail because really there's two kind of people in that group, right? There are people who it was mistimed, meaning they weren't planning to get pregnant, they were not actively trying to get pregnant, but they're relatively okay with the concept of being pregnant. And then there's unwanted, like actively trying to not be pregnant, actively using contraception, or definitely do not want to be pregnant at that point in their lives. Now, we know that the unintended pregnancy rate directly drives the abortion demand in this country. So of those unintended pregnancies, 58% went on to continue pregnancy and give birth, and 42% went on to have an abortion, which is about 2.8 million pregnancies in 2011. So 40% of those, over a million abortions in the U.S. in 2011. So this is an extremely common medical procedure. So other thing that's really important to understand about abortion is that the vast majority of abortion happens early in pregnancy, right? Over 60% happening in the first 8 weeks of pregnancy, and over 90% happening within the first trimester, which is 14 weeks. So, right, vast majority happens early in pregnancy. This is important to recognize for two reasons. One, it's important to recognize because you will hear rhetoric that talks about abortion later in pregnancy and these terms like late-term abortion, which is not even a real thing, right? Because it drives a narrative that is more eye-catching, more clickbait, right? When really the vast majority of abortion happens early in pregnancy. And it's also important to recognize that that small 10% of second trimester abortion is really, really important, because even though it's 10%, those are some of the most vulnerable people, right? There is a reason why they're accessing an abortion after the first trimester, and it's usually related to the fact that they didn't know that they were pregnant, they have a poor understanding of their body, or they didn't have classic pregnancy symptoms, or maybe they had some implantation bleeding that was they thought was a period, so they thought they were earlier. These are people who have had multiple barriers put in front of them to access abortion, whether it be cost, whether it be travel, whether it be a parent or partner trying to convince them not to have an abortion. And then a very, very small but important part of that are people who are diagnosed with anomalies. And so I say that it's a small and important part, again, because the vast majority of abortion in the second trimester is still elective, meaning that it is not due to an abnormal pregnancy. But you will hear a lot more conversations about the necessity for second trimester abortion related to anomalies, genetic anomalies, and things that are diagnosed later in a pregnancy as being the reason why we need to have access to second trimester abortion. And I would just challenge that narrative a little bit and say all people who need an abortion in the second trimester are worthy and needing of that, regardless of their situation, regardless of the normality of the pregnancy or not. So you just want to be careful about some of the messaging that you'll hear related to abortion, and just kind of understand why you hear certain tropes and certain messages and why you don't hear others. And it's because it's to achieve an end, right? It's to achieve a political end. So we can all recognize that. But in the healthcare space, we can also recognize that these are life-saving medical procedures that give people back their autonomy. So abortion's common, happens overwhelmingly early in pregnancy, and is extremely safe. right? So first trimester abortion poses virtually no risk of infertility, ectopic pregnancy, miscarriage, birth defect, or preterm delivery in a future pregnancy. It's not associated with breast cancer, and it doesn't pose a hazard to a woman's mental health. And in fact, we have good data that shows that mental health outcomes, the ability to get out of poverty or get out of an abusive relationship is improved in people who are able to access an abortion who want one compared to women who are turned away either because they don't qualify for an abortion at that clinic, maybe because they were too far along. I point out these specific things not because we actually think that these are risks to abortion, but because this is common misinformation that is used not only in rhetoric about abortion, but it's also used by state legislatures to create scripting and informed state mandated informed consent forms that say that these things are true, even though they are not, meaning that there are actual risks of these things. And so this is a little scary. I think all of us as medical providers or working in the healthcare space should be very concerned when there is state mandated medically inaccurate misinformation. I mean, if you think about the steps that state medical boards took to sanction medical providers who are providing misinformation about COVID vaccination, right? Or things like that, or about COVID itself, yet you have a state legislature actively mandating misinformation be provided to patients, which completely goes against the ethics of informed consent. So just none of these things are true, and that they are not real risks. We do know that as pregnancy advances, it does get riskier, but abortion remains safer in nearly all settings compared to continuing a pregnancy to term and delivering a newborn. We also know that with legalization, we saw a dramatic reduction in the maternal mortality and morbidity associated with abortion. And so we see, kind of late 60s, some states liberalizing their laws like New York and California, and then 73 when Roe is decided, a precipitous drop in mortality associated with abortion. And that's because we were able to actually talk about it. We were to do reporting, we were able to do quality assessments, we were able to come up with evidence-based protocols. And now abortion remains one of the safest medical procedures to be performed. In terms of who has abortions, the answer is everyone. So, but there are some particular groups that we want to highlight as being overrepresented, mostly because they're overrepresented in unintended pregnancies. And that is poor women, Black and Hispanic women, and women in their 20s, right? And so this is not a result of any group of people needing abortion more or deciding on abortion more. This is a failure of our medical system to provide access to high quality contraception, great comprehensive sex education, and other touch points to the healthcare system that would hopefully help somebody prevent an unintended pregnancy. But we're doing not a great job in that arena. So we see these groups overrepresented in the abortion patient demographic. The problem, that's already a problem, right? And we think about things getting layered on with oppression. Now you take those same groups of people and know that they're going to be the ones that are most harmed by abortion bans and making abortion less accessible, right? More costly, harder to find a provider, more socioeconomic barriers to accessing that care. And you have now this double hit on these vulnerable populations, right? So already overrepresented unintended pregnancy and abortion care, and then you make abortion harder to access. Also, important to note, these are the same groups of people who have the worst outcomes for continuing pregnancy, right? In terms of maternal mortality, morbidity, newborn health. And so not only are you signing them up for potentially forced birth, but you're also signing them up for worse medical outcomes because of inherent racism and discrimination in our healthcare system that, again, just over targets these groups of people. And this is really where I get fired up about this conversation, because it is just making inequity worse. And we are theoretically working hard as a medical healthcare system to address inequity. This is just another graphic showing how abortion is becoming increasingly concentrated among poor women, right? So And this has been going on for about the past 2 to 3 decades, where we're just seeing poor women over and over and over represented in the need for abortion care related to their higher rates of unintended pregnancy, which is why this talk is timely and appropriate for this group of people, right? Because the goal is to move upstream of people needing abortion and trying to meet their contraceptive needs and family planning needs before they have an unintended pregnancy. Okay, so that's demographics. Charlotte, is there anything I should pause for in terms of questions for demographics?
I think a question which would be helpful is to, when you say overrepresented, can you clarify that again, that language choice of that these groups are overrepresented?
Yeah, so I mean, based on their overall population percentage, right? If we were to match how many of those people exist in the population, in the reproductive aged population versus how many are represented in patients seeking abortion or having unintended pregnancy rates, they are needing abortion at a higher rate than they exist in the larger population, which means there's a higher demand there, or an unmet, in my opinion, there's an unmet family planning need in that cohort of people, which is therefore driving their need for abortion. And there's definitely a socioeconomic factor in there as well, right? People may make different decisions about family planning and continuing pregnancy based on their socioeconomic situation and the health of their family and community, which again gets back to reproductive justice as a larger concept, right? So it's not just reproductive justice isn't about making sure people have access to birth control and abortion. It's making sure that they can choose to parent when and how they want, and that they're able to parent those children in a safe environment, right? Free of violence, whether it be, direct violence, climate violence, socioeconomic violence against them. So hopefully
I really appreciate that. Yeah, that clarification and also regrounding back in reproductive justice principles. And so we had a comment that did come up, I think, as you were talking about the demographic breakdown of who is accessing abortion. And it was sort of a note that would be interesting to also see the rates for infant mortality by demographics, especially as we're accounting for, like, again, maternal and child health outcomes when there are these disparities, structural racism in place, like medical injustices occurring. And then we did have a question, and maternal, yes, and also maternal mortality rates. So infant and maternal mortality rates. It'd be interesting to see how that compares with this. And then a question that popped up said, is there any research available about the impact of restrictive legislation, i.e. waiting periods, multiple visits, required counseling on abortion timing? And I'm not sure if that's something you want to discuss now or if that comes up later.
Yeah, I mean, I can briefly, I don't have any slides on it, but I mean, definitely with the Whole Women's Health versus Hellerstedt decision in 2016, right? So when Texas imposed all of these trap laws, so targeted regulation of abortion providers, they, basically reduced the amount of abortion providers in the state of Texas by like 80%. And a very different Supreme Court decided only 6 years ago, which is wild to think about, that actually was overstepping and making and creating an undue burden on people seeking what at that time was a constitutional right to an abortion. And it was based on a lot of qualitative and quantitative research that was done looking at how long people were delayed care by those laws, as well as how many people were not able to seek an abortion at all due to those laws. And right, we have to remember, this is not a ethically neutral decision. It's not like you decide whether you want to be pregnant or not, and then decide whether you want an abortion or not, right? People often are entering into pregnancy without intention, right? Without necessarily fully being prepared for that decision. And so then your decision is abortion or forced birth or adoption, which is still forced birth, but without the parenting. And we know that has medical risk as well. And so and then again, if you look at these states that are banning abortion specifically, they have the worst numbers in terms of maternal morbidity, maternal mortality, infant mortality. So we're failing, right? This whole group of people by forcing them into pregnancy and birth, and then not giving them adequate resources to have healthy pregnancies and healthy families, which again just feels like a double hit. So there is data, I don't have it specifically, but we definitely have shown consistently that abortion restrictions do not make abortion any safer, do not improve any kind of health, public health metric, but it does make it harder to access or access later in pregnancy, or more costly, or leads people to continue pregnancy that they otherwise would not have wanted to.
Thank you for that clarification.
Yeah. All right, so we're going to talk just healthcare for a little bit, which is just understanding methods for induced abortion. I don't have any, like, there's no graphics or anything that I think is graphic, but I just like want to kind of prepare people so that this brings up certain things for you. This is all just text and conversation. Okay, so options for induced abortion in the first trimester, pretty simple: medication abortion and uterine aspiration, which has like 1,000 other names, which is like in-clinic abortion, surgical abortion, procedural abortion, a DNC, right? You probably heard all of these terms. I think uterine aspiration is at least my preferred term, because again, it just sticks to what the healthcare procedure is, right? It's using gentle suction to remove pregnancy tissue from the uterus. So medication abortion, or MAB, is becoming extremely common, right? We're getting to the point now where more than half of abortions under 11 weeks are being performed with medication abortion. And this really just goes to the fact that it's more accessible, right? You don't need as much equipment or resources to provide medication abortion. There are more places that allow more provider types to provide medication abortion, which may be more restricted for surgical abortion. So it is becoming more accessible, and therefore it is becoming more commonly chosen by people seeking abortion. So the way it works, it's a combination of two medications: mifepristone, which is a medication that blocks the pregnancy from growing, and misoprostol, which is a medication that basically induces a miscarriage so that the uterus contracts and passes that pregnancy tissue. It can be used up to 77 days in pregnancy, or 11 weeks. That protocol varies a little bit by different providers, but at least at Planned Parenthood, we go to 11 weeks. And it does require some form of follow-up to confirm a complete abortion. And I'll talk a little bit about what that looks like. Other option is uterine aspiration, which is using suction, curette, which is essentially a straw, to evacuate the contents of the uterus. This can be done up to 14 to 16 weeks alone with just suction. Beyond 14 to 16 weeks, you need to do a D&E, which we'll talk briefly about. Benefit of uterine aspiration is person leaves not knowing that they're not pregnant, right? Pregnancy tissue is removed, we confirm that's removed, the patient leaves knowing that the procedure is complete, as opposed to medication abortion, needing to have that follow-up to confirm that the medication worked. So the regimen for medication abortion, simple: 200 milligrams of mifepristone, 800 micrograms of misoprostol. Mifepristone swirled orally, absorbed by your GI tract. The misoprostol, when given orally, just creates a lot of nausea and diarrhea, and not super great therapeutic blood levels. And so it really needs to be absorbed across the mucous membrane. So that can either be buccally, so in that pocket between the gum and the cheek, sublingual under the tongue, or vaginal. And it can be used sometime between 0 to 48 hours, depending on the route. This has been studied like 1,000 different ways. And so there's like different regimens based on which method, like which route you're using the misoprostol in, and how far along you are. And it's just based on the studies that have been performed. So I didn't go into like the details here, but just know there's 3 ways to take it, and you're going to use that second set of pills sometime between 0 to 48 hours after the first pill, depending on the route, and that would all be explained by the provider. We also have good evidence now that over 9 weeks, the addition of a second dose of misoprostol 4 hours later brings the effectiveness up from, like, at that point, it goes down to like low 90s, brings it back up to 99% by using a second dose routinely. And then patients are also given supportive medications. So for pain relief, ibuprofen, acetaminophen, tramadol. If they have kind of stronger pain requirements, though routine narcotics are not necessary. And then usually some kind of anti-nausea medicine, whether it be promethazine, methazine, or Zofran. this is just a table from the ACOG practice bulletin, just showing the rates of completed abortion. And so you can see, so less than 49 days, so less than 7 weeks, and then 7 to 8 weeks, 8 to 9 weeks, and 9 to 10 weeks. You can see that the effectiveness starts to go down a little bit, but still stays in the 90s. So I tell patients under 9 weeks, your success rate is between like 95 to 98%. And then for over 9 weeks with that second dose of misoprostol, it goes up to a 99%. So overall, very, very effective. Just wanted to kind of be aware of some contraindications in case you're referring a patient or a patient asks, or just for your general knowledge. There's not a lot of contraindications to medication abortion. So one is over 11 weeks, medication just hasn't been proven to be effective that far in a pregnancy, either a confirmed or suspected molar or ectopic pregnancy, so some kind of either abnormal intrauterine pregnancy or a tubal pregnancy. If there's an IUD in place, it's for two reasons. One, if the pregnancy can't be seen yet, there's about a 50% risk of ectopic for pregnancy when an IUD is in place. And so you want to make sure that they don't have an ectopic. And two, it can, well, one, it failed. So it's number one, so you should probably take it out. And two, it can affect the effectiveness of passing the pregnancy tissue, and so it needs to be removed. So it just needs to be removed and the patient can proceed with their medication abortion. It's not like it has to be like delayed or anything, but it just can't be left in place. Long-term systemic corticosteroid use, so or chronic adrenal failure, there is some anti corticosteroid effect from mifepristone. It's more theoretical, but there's a theoretical risk of causing adrenal insufficiency. And so somebody who is immunosuppressed on like chronic steroid use or something like that may not be a candidate. Inherited porphyrias or severe anemia. So we can't control exactly how much bleeding is going to happen at home. So any extensive risk of hemorrhage or bleeding would be a contraindication as well. And then obviously inability to understand or comply with the instructions. So you have to be able to use the medication as instructed, which overall is very easy. So components of the visit, I'm going to talk a little bit about the components of the visit, but also in the background, I want to recognize that medication abortion has changed significantly since COVID, because we had the first opportunity since mifepristone was approved by the FDA to provide basically telemedicine, because the restrictions by the FDA were kind of paused during this time. So we were able to collect really robust data on the safety of medication abortion being provided via telemedicine, which is, really groundbreaking in terms of access. So first, you need to determine that the gestational age of the pregnancy is within the allowed limits. So if they're in the office, you can easily do that with an ultrasound, right? Because you both confirm how far along the pregnancy is and confirm that it's in the uterus. But we know that for, decades and decades that we could date a pregnancy by the last menstrual period if we think it's a sure normal last menstrual period, right? They have a regular predictable period that we can appropriately date them on, and that they don't have any risk factors for ectopic. And so if we can date them appropriately and they don't have risk factors for ectopic, it is safe to proceed without an ultrasound, as long as they meet some kind of strict criteria about that, and that they're comfortable with proceeding without an ultrasound, right? Some patients want an ultrasound no matter what, and in which case they would need an in-person visit. But theoretically, well, not theoretically, in reality, you can date them based on their last period and safely proceed. Also important to know that it's actually safe to proceed even in the setting of a pregnancy of unknown location. So even if they're only 4 weeks pregnant and you can't see something on ultrasound yet, if their dating makes sense based on their period and they don't have any signs or symptoms of ectopic pregnancy, you can proceed with a medication abortion. In that setting, you follow them a little bit more closely with lab work to make sure that the medication works and that you're able to diagnose an ectopic sooner. But overall, it is safe to proceed. Again, when you think about patients traveling long distances, you want to do everything that you possibly can to make sure they're able to get same-day care whenever possible. Just a note for those of you who may be referring a patient, or a patient says they're interested in the telehealth medication abortion, if they can get a dating ultrasound, either with you or at a local radiologist office or something like that, it can significantly streamline the visit. It's one less thing we have to do either in the office, or if they're doing telehealth. It's nice because then I don't have to go through this whole consenting process about these risks of not having an ultrasound, because you've already had one. You've already confirmed you have an in-stream pregnancy, you've already confirmed the dating. And so that is a nice benefit. Definitely same is true if you live in kind of more or work in more rural counties. So Western Maryland, Eastern Shore, that can definitely help that person get a telehealth MAB if they've had an ultrasound. Vital signs, not really required unless they have a history of poorly controlled hypertension. There's no specific contraindication. We also have great evidence that the risk of there being enough fetal red blood cells that can cause an isoimmunization event for an Rh negative person is, pretty much negligible in the first trimester and probably even into the early second trimester. So we actually have stopped doing Rh testing less than 11 weeks for all of our patients seeking abortion, including surgical. That those guidelines vary a little bit from professional organization to professional organization, but there definitely is strong evidence to support not doing Rh testing or ROGAM early in the first trimester. And then hemoglobin to check for anemia really only has to be done if there's risk factors for or a history of anemia. So all of these things in combination allow us to basically provide medication abortion via telemedicine, which is definitely an important concept to understand when we think about the future of abortion care, not only in Maryland, but globally. So just a quick note in case you were not aware, mifepristone, even though it is safer than Tylenol in terms of medical complications, has been under the Risk Evaluation and Mitigation Strategy Program, or REMS program, which is administered by the FDA, and basically includes like chemotherapeutic agents that can actually destroy your bone marrow or things like that. So of course, mifepristone has to be on that list as well, even though again, safer than Tylenol. And the reason why is, because people didn't want somebody to accidentally take mifepristone and not realize that it could end the pregnancy. So these requirements required that it had to be dispensed to patients only in certain healthcare settings, that had to be dispensed by a certified prescriber that was registered with the manufacturer, and the patient had to sign a specific medication consent form separate from the informed consent form. So this got waived during most of the pandemic, and then the FDA recategorized its REMS status earlier this year. And so this really opened the door for us to be able to dispense mifepristone. It didn't have to be taken in the office or even use mail order pharmacies to get this medication to patients. So those regulatory changes, plus the minimal requirements for lab testing in low-risk patients, really allows medication abortion to be done safely via telemedicine, and the medications are mailed to the patient or they can be picked up in clinic. And where I really see this having a huge benefit, right, is really patients seeking abortion in more rural settings, right? We know that 85% of counties in Maryland do not have an abortion provider in that county. We know that most of that care exists along the Baltimore-Washington corridor. And so really being able to create this kind of access for patients not having to leave their home or community to get the care that they need is huge. A quick note, and we'll talk a little bit more about the legal landscape, but we know that abortion is not legal in some states anymore. And so in this current landscape, we are, counseling as much as we can and requiring as much as we can patients to start their abortion in Maryland, right? So they have to be physically present in Maryland, either at a health center or even for telehealth, you have to be within the same state. They have to be physically present in Maryland. They can be an out-of-state resident. They just have to physically be present in Maryland for the telehealth visit. Medications have to be mailed to an address in Maryland, and the patient has to be instructed to use the medications in Maryland. Now, this would not have to exist in terms of the taking the medications and having their abortion in Maryland if it was not for the Supreme Court decision in June. But now you are looking at laws that are criminalizing both providers and patients in certain settings, and so it could be interpreted as causing or affecting an abortion in a state where it is now banned if the patient was to take the medications there.
Kyle, I do have a question about that that's really interesting. How are they able to account for patients being in a physical location if the services are provided via telehealth?
Can't. I can only do what the patient tells me.
Noted. And then a question actually popped up in the chat of, have the numbers of patients seeking abortions increased? And are there worries of folks flooding Maryland, which I know that you and I have talked so much about, and I feel like you'll probably hit on.
Yeah, I will get to that in a few slides for sure.
Great, thank you.
All right. So just a reminder about post-abortion contraception. So oral contraceptives, patch ring, depot, implant, they can all be offered at the same time as mifepristone. So in the office, if patients in the office, that can all be given the same day, so that they have immediate post-abortion contraception. With depot, because it's such a high dose of progesterone and mifepristone is essentially an anti-progestin, there's a slightly decreased effectiveness, but it's not kind of outside standard deviation. So it's still appropriate. The patient just has to be aware that if they're choosing depot, there might be a slightly increased risk of failed medication abortion. And then IUDs have to be delayed until the abortion is confirmed to be complete. So confirming that the medication abortion works can be done in one of three ways. You can either do an ultrasound in 2 weeks, but to do that, you have to have a pre-abortion ultrasound to confirm that they have an intrauterine pregnancy, so that when you look 2 weeks later, the pregnancy is gone. You can use serum HCG levels, so pregnancy hormone levels. Those should drop by at least 80% 3 to 10 days after taking the abortion pills. We shorten that window a little bit if they have a pregnancy of unknown location, in which case we want to see a 50% drop within 48 to 72 hours. So that way we can diagnose and manage an ectopic pregnancy sooner if that hormone level isn't going down. And then really where the future is going is to patient determined options, which is taking a pregnancy test 4 to 5 weeks afterwards. We know that only about half of patients complete any kind of follow-up for medication abortion. We know that the vast majority of patients can appropriately tell that the medication worked based on resolution of pregnancy symptoms and their amount of bleeding and what kind of tissue they passed. And so from a patient-centered approach, we want to be thinking, how do we not create additional barriers and visits for patients who probably don't even need that? And that's really by pregnancy test follow-up.
And we did have a question come up really quickly, Kyle, that was actually great. As we consider, it was so insightful with the medicated abortion understanding in order to sort of streamline and almost expedite the services. And especially in rural counties, folks can seek out ultrasound services, prior to their telehealth to be able to confirm a pregnancy. Regarding ultrasound pre-visits, we were wondering if patients using Medicaid, or if you have patients that are not insured, are you able to self-refer for an ultrasound, like schedule your own ultrasound, or does it have to be ordered by a physician? Because you were talking about maybe accessing local radiology centers. So again, just trying to think about what that looks like for as we are counseling, especially our under or uninsured patients, if they need to seek an ultrasound prior to abortion access.
So as far as I know, it has to be ordered by a medical provider. So it's something that we're still trying to figure out at Planned Parenthood specifically. I really look to my colleagues in Montana, right? Montana, huge state. Lots of people live very far from each other or a city or a Planned Parenthood clinic. And so they have developed relationships with radiology centers across the state. They have cash price, so it's, whatever, $100 or whatever it is for their ultrasound if the patient is un or underinsured. So they're ordering, patients, says they're seeking an abortion. They do the assessment. They say, you really need an ultrasound before we can do a telehealth visit. Instead of saying drive 3 hours to Billings, they say go to the radiologist in your closest town, get your ultrasound, send that report to us. Now we've confirmed that you have an intrauterine pregnancy, and we can proceed with a telehealth visit. Maryland, it's a little bit closer for most things, and so it's something that we are still figuring out at Planned Parenthood. But if you have a patient that's in your practice who has a recent pregnancy, theoretically you could still refer them for an ultrasound, and then they would just bring the report to their visit, telehealth visit, or in person. That's a good question. It's something we're still trying to figure out. We just launched these telehealth services a month ago, so we're still fresh. but the data has, really existed for the past couple of years. All right. So quickly, uterine aspiration, again, simple same-day procedure, pregnancy tissues removed with gentle suction. Pain management includes NSAIDs like ibuprofen, paracervical anesthesia, think about like a, kind of getting numbing from the dentist, and then sedation if the patient desires it, mild, moderate, or deep, which includes like an anxiolytic like Valium or midazolam, and a narcotic like oxycodone or fentanyl, depending if they're getting oral or IV. Visit usually takes a few hours, ultrasound, get your counseling, get your preoperative sedation assessment, do the procedure, recover. So it's a bit of a longer visit, but overall is, same day, leaving not pregnant. Post-aspiration contraception, you can essentially start all of the methods same day, including immediate placement of an IUD at the end of the aspiration once you've confirmed that the uterus is complete. I go a little bit quicker just because I want to talk about some policy stuff. This is just a table going over kind of how to help somebody decide between medical and surgical. Main thing is, do you want to avoid an invasive procedure or not? Are you okay not being sure or having to wait to know that the abortion worked versus wanting to know immediately that it was effective and done? I would say those are the two big questions that patients have to kind of self-assess when determining the right option. A quick note about DNE. So dilation evacuation is the most common form of abortion in the second trimester, and just some kind of notes for helping patients navigate what to expect if they are later in pregnancy. So up to 18 to 20 weeks, depending on the provider, could potentially be accomplished same day with medication and osmotic dilators, which basically help dilate the cervix over time. But generally around 18 to 20 weeks is when you're likely going to need a 2-day procedure. So these dilators are placed in the office on day 1, and then the DNE is performed to remove the pregnancy on day 2. And this, pretty much always requires at a minimum moderate IV sedation, if not deep sedation or general anesthesia for patient comfort. So I want to make a quick note about self-managed abortion, just because I think you're going to hear conversations about it, and I think it's important to just level set how we talk about it. So self-managed abortion is the concept of a pregnant person inducing an abortion with medication or other methods outside the surveillance of a medical provider. And we often think about self-managed abortion as a consequence of a lack of access to, medical provided abortion. But I also want to recognize that this is also a patient autonomy issue, right? So if a patient otherwise has access to safe medications and prefers to do this outside of the healthcare system, or has been traumatized or victimized by the healthcare system previously, this may be the safest, most effective way for them to accomplish this goal. So it's important that we center patient autonomy when talking about this. Also, I think with this Roe getting overturned decision, there's been a lot of like imagery and discussion about coat hangers and this stuff. And then you probably have seen a little bit of like pushback from reproductive justice advocates about like how this imagery can be a little stigmatizing, because self-managed abortion just looks so different than it did in the 60s and 70s. And so we both have to like recognize our history. Like I don't want to devalidate all of the work that it took and how many women died to get the Roe decision. But I also want to recognize that self-managed abortion looks very different in 2022 than it did in 1973. Right, we have medications that are highly effective, that hopefully are going to reduce the incidence of abortion complications when they, if a patient is using self-managed abortion techniques. So just wanted to say that, just so you had some language around it, can maybe understand some of the controversy about coat hangers. And also remind people that self-managed abortion cannot medically be distinguished from a miscarriage. So it's really up to the patient to disclose that information, or, in the case of some states, up to the state to criminally investigate to determine those things, which is horrifying. Okay, so now it's to the really depressing part of the talk. So understanding policies regulating abortion in the US. Okay, so go back in time, 49 years ago, right? death from illegal abortion accounted for at least 1/6 of maternal mortality. And the Supreme Court at that time said, well, the decision to terminate a pregnancy is really an issue of privacy between a woman and her doctor. There can be no state restrictions in the first trimester. And in the second trimester, up to viability, the state could impose restrictions on abortion only if it benefited the health of the mother, and any other type of regulation would require a compelling state interest. Quickly thereafter, the Hyde Amendment was introduced, right, which prevented federal funding for abortion services except in the case of life-threatening condition to the mother, rape, or incest. This is why our worlds of family planning are split. Like, this is the reason why we can't talk about Title X and contraception and abortion in the same conversation in so many spaces. This is completely imposed, even though we know to a patient, those things don't live in separate spaces, right? Pregnancy prevention, unattended pregnancy, parenting, they all exist in the same person, right, at different points in their life. And we just artificially separate those things into literally physical separation, fiscal separation, and therefore we stigmatize it, right? Because now abortion exists in this silo, which is easier to attack and politically bully, because we lose all of our family planning partners by being in like literally physically separated spaces and having different support from state and federal entities. So in addition to it making our lives hard as reproductive health providers, this specifically targets poor women, women on Medicare, active duty service members and their dependents, federal employees, Indigenous people served by Indian Health Services, right? So again, we see systemic, structural racism and discrimination creating health inequity based on where we're allowing federal dollars to go. A few years later, Planned Parenthood of Southeastern Pennsylvania versus Casey expanded the state's ability to regulate abortion. So instead of it being only directed at maternal health, it could actually regulate abortion at any point, as long as it didn't create an undue burden on the woman seeking an abortion, which was incredibly vague and really stood until 2016, when the laws were so bad in Texas that they actually said that they were creating an undue burden, and those trap laws were overturned, which was, the first kind of win for abortion care in a very long time. Okay, so now let's get to June. So Mississippi introduced a number of laws regulating abortion that clearly created an undue burden of patients. This was including a law that prohibited abortion after 15 weeks and threatened physicians with civil penalties for providing the care. This was blatantly unconstitutional based on Roe. And so the Supreme Court had no reason to hear this case, right? They had not taken any of these cases for decades because they blatantly would contradict the decision in Roe. Well, they did take the case, and so it became very clear to those of us in this field that they must have assumed or decided that Roe was not decided correctly, because there would otherwise be no reason to take this case. So we have really been preparing for this long before the oral arguments in December, and even before, and definitely before the decision in June, or even the leaked decision in May. We knew the direction that this was going. Didn't know it was going to be this bad, but we knew the direction it was going. And so ultimately, June 24th, in a 5-3 decision, decided that Roe and Casey were both decided incorrectly, and overturned that decision and essentially passed all decision-making about abortion regulation to the states to restrict as they please. So as of today, this is where we exist right now. There are, I believe, 16 states that now have bans in effect. So the dark maroon are states that have total bans, right? Some of those have no exceptions for rape or incest. Some of those have criminal penalties for providers, i.e. felonies, i.e. life sentences. Some of these have criminalization. Most do not have criminalization of patients, but some do. And some of that is criminalization of self-managed abortion. Georgia and Ohio have 6-week bans right now. South Carolina did have a 6-week ban That was enjoined last week. It will probably come back, right? A lot of the like state of play for the past 60 days has been the fact that states that have trigger bans, most of them had a 30 or 60-day like maturation periods. They couldn't enforce the ban, or there was like procedural things that abortion proponents could do to like delay it going into effect, right? Because every day that abortion is accessible is another day that people's lives are going to be protected. Utah has an 18-week ban, Florida has a 15-week ban, and then North Carolina, which has very much been trying to protect abortion, one rogue judge decided that their pre-Roe 20-week ban could go into effect just unilaterally without any guidance from the state. So, so when you think about where are the safe places to go, particularly if you think about the Southeast and the Midwest where most of this is happening, you're really looking at Colorado, Kansas, Illinois, and then North Carolina, Virginia, Pennsylvania being the like safe havens for people to get to as like the closest driving distance. Florida technically is there, but you know, they have a interesting governor. I'll leave it at that. And I'm from Florida, so I can say that. All right. So what are the effects of these policies? So despite its safety, which we have made very clear, abortion is the most highly restricted outpatient procedure. These state bans overwhelmingly affect poor and under-resourced women who now have to leave their home to access basic health care. And you know, they really bear, not only do they have barriers to accessing the care, they also bear the largest burden of morbidity and mortality for continuing pregnancy. No state policy has ever been shown to improve the safety of abortion or benefit maternal health in any way. Many of these policies don't have exceptions for rape or incest, which, you know, makes some people somehow feel, you know, better about allowing abortion. And I think what is really what we've been figuring out for the past 2 months is these policies are creating significant conflicts between the standard of care and the ethical duty of medical providers to treat life-threatening emergencies in a timely manner, and the legal chaos that they have been thrust into and not knowing what they can safely do to take care of the patient in front of them. And I think the language that we keep hearing is, how dead does my patient need to be before I'm able to act, right? Like what is that? Like how much have they have to have hemorrhaged? How septic do they have to be, right? The whole goal is to treat life-threatening emergencies before you get to, you know, extreme situations. But now we're having medical providers directly pitted against this life-threatening language, which is really dangerous, especially when they could be facing jail time and losing their license and losing their livelihood and all of these things. Luckily, we live in Maryland. So a few things on Maryland. Parent of a minor must be notified before an abortion is provided. And health professionals are allowed to waive parental involvement in limited circumstances if the minor appears mature enough to make the decision. Medicaid coverage will no longer be restricted as of January 1st, 2023. So these came from the abortion access bill that was passed this year. So this includes, so right now there has to be like an indication for mental health or physical health or things like that. Those justifications for Medicaid coverage will be going away. There will be no cost sharing or deductible for abortion care for those with Maryland commercial insurance starting in January 1st. Medication and surgical abortion can now be provided by advanced practice clinicians like nurse practitioners, midwives, and PAs. That went into effect as of July 1st. And we already have people training in various places across the state. And there is a significant amount of funding that will be available for institutions to train additional providers in Maryland, which many of you probably know that is currently being held by the Hogan administration. And so either could become, you know, available with the next administration, or at the latest would go into the 2023-2024 state budget. So what can Maryland reproductive health providers do? What can people on this call do? Well, you know, first and foremost, what we know how to do, which is we need to increase equitable and timely access to all of the available contraceptive methods, which will hopefully reduce unintended pregnancy and thus the need for abortion. And so my question to you and for your teams to think about is, how will you fill the gap, right? Particularly if family planning providers who also provide abortion care, like Planned Parenthood, have to pivot to increase abortion access for those in Maryland and those traveling to Maryland for care. Consider how you could provide family planning services to those living in areas without a current family planning provider, i.e. how could you use telehealth to provide contraceptive access to people? Something that's been really interesting, scary but interesting, since the Supreme Court decision, we've seen a significant increase in patients seeking information about permanent contraception, so i.e. permanent tubal contraception and vasectomy. So think about how you could increase access or referrals to providers of permanent contraception is important. Making sure that you have streamlined and efficient referral processes for patients seeking abortion care. So because we know that access may be limited if Maryland sees a surge in the future. And, depending on how you're funded and what you do, consider providing abortion care in your practice, right? Medication abortion can be easily provided. And so maybe something to think about. So, in terms of the surge, I think it's obviously a question that's on a lot of people's mind. We have multiple data modeling scenarios that we personally at Planned Parenthood are watching, on a daily to weekly basis. In talking to the Baltimore Abortion Fund, talking to other abortion providers in Maryland, we have not seen a surge yet. Definitely Illinois, Kansas, Colorado, North Carolina, they are bearing the brunt of that. But I want to remind people that we are very strategically located and precariously located. So strategically, right, we're on the I-95 corridor. BWI is a Southwest hub. We have great train, plane, driving access. And so we are a relatively accessible state for people further south or west. We're precariously located because really our barriers right now are North Carolina, Virginia, and Pennsylvania. And all three of those states have precarious political situations that could easily, with gerrymandering and redistricting, could easily change what abortion access looks like in those states, and then would set us up as kind of the first hated state. And so we are watching all of those states closely. We are talking to providers in all of those states to make sure that we are supporting them. And we also know that there will probably be a domino effect, right? They will get overwhelmed. And so people will go past them for access, or people in those states will have to travel to the next available state because they can't get care within their own state because all the people coming into their state. But another sobering fact is that 50% of, at least the data from Texas, when SB 8 went into effect in September of 2021, there was like an immediate 50% drop off in people seeking, like not seeking abortion, but able to get their abortion, right? So we know that there's also just going to be a huge number of people stuck in those states, continuing a pregnancy against their will. And so, just obviously hoping that they do something conscionable and help make pregnancy safer for people. Two quick resources: abortionfinder.org, great resource for patients, the unified single resource to find the nearest abortion provider. It's constantly updated as access changes. And then Plan C Pills is an online guide for people trying to access abortion pills in all 50 states. I will leave it up to the patient, the person, to decide the legality of that, but the information is there and includes online calculators and instructions on how to take the pill and information on self-managed abortion. I apologize for going over time, but I'm happy to stay on for questions if that is appropriate. So this, I know, I'm sure there's a lot.
Thank you so much, Kyle. I really appreciate this. And so folks have a little context, and I definitely put it in the chat. I understand that we are going over, but we're going to kind of keep going to just really finish off this session. So if you're able to stay on for, another 5 to 10 minutes, that would be awesome. If not, you'll be able to access the archive recording. We do have some questions that are coming in. And again, for the folks that are attending, this is great clarification. Part of the intention of this presentation was to really walk through what is abortion, what services are available, in addition to the policy side, because we know that all of us are working at really different talking points with our patients and our communities, whether we're social workers, case managers, health educators, actual medical providers, administrators of clinical services, or even just social services in general. Like we're all having these conversation, as Kyle had mentioned, in this like very nuanced way that's fluid and connected, and it's not dichotomous or black and white of like, well, we talk about abortion, pause, and then we talk about family planning, pause, and then we talk about pregnancy. It's all the same conversation. So I think being able to lay this out has been so incredibly helpful. So thank you, Dr. Bukowski, for that. I think, so one of the questions that came in is, are we doing anything to provide transportation or housing for people coming to Maryland for abortion care? Kyle, I'll let you take on to that, and if need to, I can add on to it too.
It's a great question. So something that we have been also trying to recognize, right, is there have been networks of abortion funds and reproductive justice organizations who have been helping patients, right? Roe has been, right, insufficient since it was decided for all the people who are now in banned states. Even before that, Roe did nothing for them for access, right? Like theoretically, abortion was legal in their state, but there were so many hoops to jump through that it was nearly impossible to access. And so, at least some of the conversations that we have had here at Planned Parenthood have been, right, how do we partner with these organizations that are already doing this kind of practical support and funding work, and not trying to reinvent the wheel and insert ourselves to do work that is already being done. So the Baltimore Abortion Fund, the DC Abortion Fund, Blue Ridge Abortion Fund, the National Network of Abortion Funds, really they've been doing the work to think about how do we help patients navigate, right? So navigating is helping a patient find an appointment and resources. How do we help patients wayfind, which is patient-driven navigation, essentially? How do they get the resources to find the appointment and find the funding? And so we are working very closely with these different organizations to make sure that funding is available. I would say right now, there's going to be a lot of money, right? It's a very acute issue, but we also know how these things change over time, right? The new shiny object of tragedy comes up, and so therefore funding wanes in other places. And so I don't know long-term what that looks like, but I can say right now, Baltimore Abortion Fund is working on as part of like a national grant for Operation, I think it's like Operation Scale Up or something like that, where they're like 100% resources for people seeking abortion, whether it be financial, transportation, housing, food, things like that, to help people get the care they need. And then connecting with abortion funds in places like Missouri and Tennessee or whatever, because those abortion funds are still there and they can help patients navigate out of that state. If you couldn't think about this getting any crueler, places like Texas specifically targeted and intimidated abortion funds in Texas to say that providing the funds for a person to leave the state and get an abortion out of state was essentially providing the means for an abortion that violated the state law. And so some of those abortion funds closed down immediately after the June decision, and they're thinking about relocating out of the state. So it goes beyond just like banning the procedure. It's like banning information, banning resources for people to get care outside of the state. I mean, it's really wild, the kind of criminal and political posturing that is happening right now. Horrible, but it's real.
And yeah, that's and I think just really re-emphasizing, and we like the fact that exists the Baltimore Abortion Fund, and while it has the name Baltimore in it, it's really for folks coming into Maryland to access these services. And they talk a lot about that they are serving, like there's a portion that, of patient seeking services and support that are in Baltimore, some that are outside the city, that are across the state, and also out of town or out of state folks coming to Maryland to access services. Anyone can access these funds. And as Kyle has mentioned, it's like not only to create financial support if you're seeking the services, because we know that there is a spectrum of cost depending on at what point in the pregnancy you are accessing the services, but it also includes financial support for transportation, for hotel lodging, for food while you're here accessing that care. So a website like abortionfinder.org really is accounting for all the abortion funds all over the country. So that way, if folks are seeking services in another state, they can also look at that. And somebody did put in here, which was really helpful, and I forgot about them. I shouldn't. Abortion Doula Project, or excuse me, Baltimore Doula Project. Amazing folks, doulas who are trained not only in providing prenatal, birthing, postpartum support, but also can provide abortion doula services. And so they're excellent. So being able to provide that physical as well as emotional support as somebody is accessing abortion. So definitely worth looking into them as well. And again, while Baltimore is in the name, it's not just specifically for Baltimore residents. So folks here accessing services.
An abortion.
Yeah. Exactly. I'm just kind of going through comments that are being thrown in here. Emergency departments and other acute care clinics do need training around education and training for patients coming in with missed abortions or complications like hemorrhaging. And so that's part of that like broader spectrum. I think that Kyle, you had touched on it, that funding that was sort of promised within the Abortion Care Act of this past legislative session that would also help get more primary care providers trained, I believe, in abortion care services. And
yeah, it's unclear how the grant's going to be administered. And obviously, that's like the next step. Once the funding is available, is getting the third party that's going to administer the grants. But this brings up another issue, which fires me up, which is there's also, right, this absolution that other healthcare providers have enjoyed for the past 50 years, which is like, I'm a primary care doctor, I'm an anesthesiologist, I'm a radiologist, I'm an ER doctor, this doesn't affect me, right? That's for the OBs and the family med docs or the abortionists to deal with, right? But we know that when people aren't able to get abortion care, they are going to have other medical complications, right? And therefore need general surgeons and ER doctors and anesthesiologists and radiologists, all these things. And we really have to be working together, as a medical community, because this affects all of us. It doesn't just affect people who provide abortion. And I think we should all be outraged, right? I think if anybody in a medical provider or healthcare provider is being criminalized for providing standard of care, basic healthcare, right, being threatened with felonies and $10,000 lawsuits and things like that, everybody should be upset, right? Like if gastroenterologists are getting, threatened by the state and with felonies for providing colonoscopies, like I think we would all be pretty upset about that, even if we don't provide colonoscopies. But again, the siloing of abortion care and the stigmatization of abortion has made it easy to like leave those people behind. And so I hope that we can continue to work as a unified, healthcare provider community to make sure that we are advocating for all of us, right? Because when patients get the care they need, we have healthier communities across the board.
Superb. And I think ending it kind of there. I mean, I know folks are feeling outraged, and we're also sharing resources within the chat box of like how to access services either in person or telemed. And if needed, we're also happy to send that in the post-meeting materials. Because just a reminder, just even if you are not a provider of abortion services or working in an abortion clinic, we have earned a right, literally in higher U.S. district courts, the federal courts, to protect our ability to provide non-directive medical counseling. And so if we have patients that are coming in that are pregnant and want to know what those options are, even if we are not an abortion provider, we have earned that right. We have secured that protection of that right in the state of Maryland to be able to provide non-directive counseling on those options. So just a loving reminder, even if you have federal dollars helping to pay for your health education services, medical services, social work services, you actually have the right to be able to provide non-directive pregnancy option counseling and referrals out to care. So just a loving reminder of that. So yeah, I think on that, I want to really bring us to a close. I am so appreciative, Dr. Bukowski, of your time and just really walking us through that. I know there might be additional questions or resources being sought. So if those questions come up, you guys are more than welcome to email me. We'll also share Kyle's contact information. You're welcome to reach out, and oh, Dr. Bukowski just put it in the chat. So we'll also send that out in the post-meeting materials. And it's just really kind of creating that supportive network so that we are aware of what medical services are provided, because as Kyle has mentioned, we have come beyond the days of these back alley and, you know, clothes hanger narratives. And so really, you know, a lot of the goal of this session is to remind us, as we provide counseling to our patients, to our communities, that there are medicated abortions or telehealth services. There are ways folks have more direct access to this. And in some ways, like, thank goodness we are in a right now protected state for abortion care. So more resources will be shared. Again, abortionfinder.org for accessing funding and services is an excellent resource. Everybody, let's give Dr. Bukowski a round of applause. Thank you so much for today's session. We will be sending out the meeting slides as well as the recording in our post-session materials. If you have questions around the certificate of participation, please reach out to our Healthy Teen Network partners. And please, please, please check the evaluation link in our chat box. So that way, that information is so incredibly helpful, and it could also help direct some of the resources that we're able to put together in our post-meeting materials. So everyone, please take care of yourselves. Wishing you all a safe and restful long weekend. And until we all collectively meet again, you know, be safe, be good. Thank you, Dr. Bukowski.
Thank you. Have a great day.